So I think we are going to start. Thank you very much, everyone, for coming to our Innovative Discovery series. We are delighted today and honored to have Dr. Weinstein from the Asthma Management Systems organization to give us a talk about asthma management. But before I introduce him, let me mention some housekeeping issues. For CME credit, you must sign in and you must include your emails and credentials, and the signing sheet is on the table. Don't miss our February 1st tech talk with Dr. Paul Combe from now MedStar Health, who is coming, who will come back to us. So we are very excited to have him back. And also please note that our next ID series lecture will commence January 12th, 2018. And please register to help us prepare, and mostly so that we have enough food. And again, the full schedule is posted on our website, DE-CTR.org. And finally, I'd like to remind you that registration is now open for the ACCEL Community Research Exchange on March 12th, 2018. The keynote speaker for this event is Dr. Georgia Dunstan. She's a founding director of the National Human Genome Center based out of Howard University, and she's an accomplished speaker on health disparities and genomic research. So please register if you haven't done it. So Dr. Weinstein is currently the president of Asthma Management Systems. He got his MD from University of Pennsylvania and did his pediatric residency and fellowship in pediatric allergy and immunology from the Children's Hospital of Philadelphia, from CHOP. Prior to being the president of the Asthma Management Systems company, he was a director of the Asthma Rehabilitation Program at DuPont's Institute of the Nemours Foundation, and also for a long time in private practice. He has served in multiple national and international committees regarding asthma treatment and management, notably from 2001 and 2004 in the scientist group of WHO Project Adherence to Long-Term Therapies. He was also chair of the Health Outcomes Education Delivery Quality Interest section for the American Academy of Allergy, Asthma, and Immunology, and is currently the director of the Adherence and Communication course, also for the American Academy of Allergy, Asthma, and Immunology. He has been co-PI on an NIH grant related to the computerized adaptive assessment of asthma impact, and is currently PI on an NIH Small Business Investigation Research Grant, or SBIR, which objective is to determine the effectiveness of medication monitoring and motivational interviewing adherence strategies in asthmatic adults. He is also a very prolific author with a long list of peer review publications. So thank you very much for being here, and welcome. We have 1 hour. I mean, no, sorry.
Sure, you do that. Thank you. Well, thank you very much for inviting me. This whole presentation was, this is my financial disclosure. The seeds for it was in July at a Delaware Bio conference in which Christianity Care hosted and had 3 presentations on analytics. Sharon Anderson, Muge Kapan, and Ed Ewan had an interesting take on how analytics can be very helpful in healthcare. And I thought about this for a while. And from the back row, I usually sit in the back, sort of remnants from junior high school. What's happened is that Dr. Ewan more or less presented the analytic requirements. And he talked about descriptive, diagnostic, predictive, and prescriptive. And over here, you can see that adherence was part of the analysis. So I thought maybe I could, having talked to these individuals and Dr. Jordan, to have a presentation here about asthma adherence. And I thought I'd just start out real front with present some outcome slides from my AI DuPont Nemours Children's Hospital, where I was the director of asthma rehabilitation. We had a program that was an inpatient. It lasted 10 days. Parents had to participate in 4 days with the group. My background is allergy, immunology, but also heavy into psychology, and with 2 years training in family therapy. So it gave me a good opportunity to apply behavioral principles to see how we could help these individuals improve their health. And what happened is that 1 year prior, the total cost, the median was $10,000, had 7 inpatient days, 4 emergency room visits the year prior. And then they were put in this 10-day program. And then they were followed as outpatients. And most of them were taking theophylline, which was a drug that was not used very much now. It has a small therapeutic window, and you had to dose the medicine with blood levels. And that was a perfect marker for adherence. So individuals would come into the clinic after discharge, and then we would get a blood level, and then the focus was often, well, where did the theophylline level go? And what we found that by using this feedback and multiple strategies, we were able to have 0 hospitalization and 0 emergency care over all 4 years of follow-up. And this more or less, I felt that I was sort of on the right track and would want to continue with this type of work. So what we more or less did then and figured out, give it a name later, was develop what's called the Asthma Adherence Management Model. And there are 4 components to this. First would be objective diagnosis for adherence. Second would be identify patient-specific barriers to adherence. Then you look at strategies to overcome the barriers. And then you use patient-centered communication skills as a way to enhance delivery. And that's pretty much what we're going to focus on. And then at the end, we're going to look at a study that I completed recently, funded by Merck, trying to figure out how to help adult asthma patients improve their Dulera adherence, as well as improve the asthma control. So the definition for adherence is the extent to which a person's behavior, taking medication, following diet, or executing lifestyle changes, corresponds with agreed recommendations with the healthcare provider. And I think this is different than what would be termed as compliance, where the prescriber or the clinician is more or less giving specific directions to the patient without consultation or asking consent from the patient. And it's estimated that the cost of non-adherence is $100 to $300 billion. This is primarily into the hospitalization, emergency room visits, physician visits, and laboratories. But it's really only an estimate because no one is actually being able to identify at the point of hospitalization or emergency care whether the individual actually followed through with treatment or not. And the estimation for non-adherence in various diseases is 40 to 60 to 70%. But the point here with this slide is to say that if there is the ability that if adherence is improved, then individuals have a chance to lower costs. And I think that is a key component for the outcomes research. And here's an example of slides from 1 year prescription data refill for inhaled corticosteroid. And we have 2 colors here. The black is adherence with once a day medicine. The gray is adherence with 2 or more often twice a day medicine. And you can see the descriptors, but the thing to look at here is at the bottom. You'll see that with twice-a-day medicine, once-a-day medicine, the adherence is 40%, but with twice a day, it's only 20%. And this is prescription data, which is not really the strongest data when determining adherence. And for patients with moderate to severe asthma, it's the same. You get the feeling that there's a major issue with people not following through with treatment. So this is what I would call precision medicine. This is a slide that more or less says that a patient is symptomatic and on a specific drug, and you evaluate for adherence. If the patient's adherent, then the treatment would be to select stronger therapy or further evaluation. But if the patient is not adherent, then you wouldn't want to up the treatment. You would want to put them in an adherence education program. And something like you find out the reasons for poor adherence, and you have specific interventions and improve communication. So unfortunately, a lot of physicians aren't able to practice precision medicine because they don't have accurate measures for adherence. This is a slide from the NHLBI guidelines. More or less, I call this the Manhattan skyline. And you start here with low treatment, and as you step up, you take higher and higher treatment. But the point is that when you do decide to evaluate that patient who is failing treatment, you first have to check for adherence. So it is the NHLBI asthma EPR3 understands that, but they make it difficult for us because we don't have the effective measures widespread to use them. So I'd like to talk a little bit about the ways to objectively identify adherence, and also start out with subjectively. And you can question the patient, evaluate diaries, and ask the patient to complete a questionnaire. And one of my partners, Hippocrates, came up with this quote. He said, "Some patients are not truthful." And there is a reason for that. When you go to the doctor and you didn't follow through with treatment, you're either going to go, "Yeah, doctor, I'm non-adherent. I should have followed the treatment." A lot of people will go, yeah, I took that. And they don't want to be embarrassed in front of the physician. Also, the physician, when they prescribed the medicine, might have been using heavy-duty medical terminology, and they were embarrassed to ask what that meant. And lastly, they may get the feeling that the doctor really didn't care at all, so that's one of the reasons why. Regarding diaries, this is a study of 24 children then at National Jewish Hospital, in which individuals were given a diary, and the parents said that they were at 95% adherence based on the diary. They were given a tracking device, a chronolog, an early one, and they found out it was really only below 60, and that only 30% of the doses were taken at time. So not too impressive. But this is key. When they broke out the patients to see who was having a bad day taking oral corticosteroids and who wasn't, they found out that 16 did not need oral corticosteroids, and their adherence was at 70%. But when they looked at the 8 that required prednisone, they found out that the adherence was 11%. So if you didn't have the chronolog and you were relying on the diary period, you would have assumed that you had 8 cases of bad asthma. But in reality, with this type of precision diagnostic tool, you really just had 8 kids in which parents didn't follow through with treatment. So diaries themselves are not the way to go. Another way to evaluate adherence is to have a questionnaire. there's a Dr. Morisky who has figured out that he can ask 8 questions, and on the basis of a score from his 8 questions, he can predict who's taking the medicine and not. Questions like, do you sometimes forget to take your high blood pressure pills? Over the past, were there any days when you did not take your pills, et cetera, et cetera, et cetera? And this is what he got as data. What he found was, on this axis, was the percent of blood pressure control. And on this axis, the different scores. And what he found is that the higher the score, the better control. So this would be one way to evaluate adherence based on physiologic outcomes. Not too strong. There's a technical problem with that, because not everybody who is adequately controlled has a score that has a high adherence score. So here's individuals that had 94 individuals were predicted based on the score. 31 were predicted as high score, but the 31 had inadequately controlled blood pressure. So you might be able to run this in a large population of patients and get a guess of what their adherence is of the population. But if you go to the person specifically and there's a mismatch, that's not very helpful in a clinical model. And that's the advantage of having more precise treatment. From an objective point of view, you can do pill counts. Okay, that's probably it. That's not too accurate. You can use electronic monitors, measure levels of medicines like in the blood or urine, the way that I use theophylline as a way, or you can look at prescription refill. And here's an example. There's several companies out now, and there'll be a myriad of them in 5 years, helping clinicians get objective measures. And this is from the propeller, and they have a little business end here on the top of the canister, and it's fixed there. And every time you click on it, through Bluetooth technology, it goes to a hub or your cell phone and then to the internet. So you get a printout of within several minutes of how that patient is done on this specific day and this specific time. Now, the advantages of the electronic adherence monitors are they're accurate, they're easy to use, and easy to have access to data anytime you want. You can help the patient. You can understand why the patient is, you can see the patient's use of the medicine and understand then the actions. And you can also support or develop behavioral interventions based on the type of non-adherent pattern that is presented. So the problem with these electronic devices is that they're not feasible for long-term trials or in large-scale populations. They're complex, they're costly. There's a patient burden that they have to cooperate. There's a limited availability of these, and that there's patient fatigue. They tend not to use them. So that's the story with the monitors. And here's an example. Individual is supposed to be taking 4 puffs a day, but you can see that they're only taking 2 here, 4 there, 2 here, 4 there. So you can begin to see and ask, oh, what happened over here? And they said, oh, I went over to grandma's and I forget, stuff like that. So you can really then cue in what's the situation is for that patient. Now you have access to pill bottles, wireless, and here every time you open it, you disrupt it, and you have sent a message to the internet. And this, I just put this next to another one to show you that it's not a 12-gallon size thing, but it's real-world size for the patient to use. When you try to figure out what's going on with adherence, it's sort of tough I want to give you just a quick overview on how to think about it, and then we'll show this in relation to some prescription refill data. So we have the first prescription is written over here, but they take the first dose over here. So there's a lag that, and this is called initiation. And you can see that the white areas are areas that they missed doses. And then you can see that this is the track of the last dose here, and that's called discontinuation. And then this is the end of the prescribing period. So if one were to go as an overview, one would say, this is an example from here to here of persistence, and this over here is non-persistent. So prescription refills have its pros and cons. It works out best when it's really close between when you get the prescription and when you start it, the initiation. You need to have, as part, when you look at this data, you need to have standard dosing and prescribing information given on that individual, or else you won't know what you're dealing with. You need to know what is the source, who is prescribing this or not. And if that's not there, you have a problem. The good thing is that it's really easy and it's really cheap. So sometimes things that are really easy and cheap aren't necessarily great. Now the cons are that it's imprecise in that you start the game when it starts out at a 3-month level, because that's where the prescription is. And so you don't know what's going on until they hit the 3-month mark. You can have, if you stop the treatment, it's not clear. You don't know whether there's other medicines involved, but you don't know whether it's the same medicine or a different medicine, because it could be tracking multiple treatments. And it may not be all on one pharmacy. This could be in different pharmacies or health plans. So prescription refill has its good points and its bad points. Just to briefly say, there are a couple that are used more than others, but more analysis is always ongoing. First one's called the medication possession ratio. And there you add up the days supply for all the fills, and you divide it by the number of days in the period, and multiply it 100%. And you can see that that's going to overestimate adherence if people aren't utilizing the medicine. The other one is called proportion of days covered, EDC. And here they use the number of days covered versus the number of days in the period. And this is used as a more conservative measure than NPR. And it counts, it avoids this overlapping nature of different medication. And it's most suitable for individuals who are given multiple medications. And it's pretty much its endorsement is that it's used by Medicare and Medicaid. So first part of the model was identification of adherence. The second is identify barriers to adherence. And this is a sort of a complicated slide, but really it looks at the selected determinants of medication adherence. And you got demographic, sociocultural, and I'm going to highlight here the question of medication beliefs. You have behavioral, psychological issues, and this is all for the patient. For the provider, they have to overcome these obstacles: communication, the relationship with the patient, and agreement on racial concordance. So that there has to be some real joining of the patient and the clinician so that they can overcome these problems. And then you have external factors such as the disease and the duration, types of medicine, and then the system, and then access to system. So these are issues, and I wanted just to touch on one that had to do with the idea of beliefs. There's a school of thought that is very popular in adherence research. It's called the necessity concerns framework. And that basically says that individuals who have doubts about personal necessity of medicine or have concerns about potential adverse effects will be more than likely not to follow through with treatment. They'll have low adherence. And this is in part developed, if you keep going back, everybody says the same things, they change the names. I don't know whether people are familiar with the term health belief model, but the health belief model was developed in the 1950s by the University of Michigan investigators trying to figure out how to get the population to get polio immunization. And they figured out that individuals who thought that they susceptible to disease, disease was really severe, and they thought that there were no downside from the treatment, then they were more likely to follow through. And this is just another picture of these beliefs, so that if you have a patient and they don't think that they need the medicine, or they have concerns about treatment, and you're not going to do it. But the only way you're going to find out is you have to ask. So the Global Initiative for Asthma was nice enough to publish a list of barriers involved in non-adherence to asthma treatment. And they looked at drug factors, difficulties with the inhaler, frequent treatment regimens, side effects, cost, dislike, and then non-drug factors, fears, sort of like what we were just talking about, misunderstanding, lack of instruction, unexpressed inappropriate expectations, etc. And these are things that if you have a method to identify or give a patient an opportunity to find out this is the case, then you have something to discuss and to avoid potential non-adherence. Once you identified the barrier, then you'd want to figure out what's the best strategy. Pretty straightforward. So what I had here is I sort of highlighted these issues that were the barriers for non-drug factors. And to show here, these are the same list of problems on the left, but adherence strategies that we use as part of the Merck study and the NIH study. Once the patient has identified what the problem is. Now, adherence strategies come in different sizes. Education, which usually doesn't work. Communication strategies, which I'll mention in a few minutes. Prescribing, using the medicines less frequently. Behavioral, self-management, increasing frequency of seeing the patient, giving patient direct feedback, having the patient self-monitor, using reminders, rewards, and different types of psychological therapy. So there's a variety of things, and these can be used not individually, but together when appropriate. Here's an example of what feedback would look like. Here's 19 adult asthma patients, and they were given, half of them were given tracking device, and they weren't being told that they had a tracking device. And actually, sorry, these people were told that they had a tracking device and that they were to come in each week. And the people down here were in the control group. They were given the tracking device, but not told that they were being monitored. And you can see that the adherence went from 60 to 80 and stayed at around 80 when giving feedback to the patient about the medication use. Whereas these individuals just sunk to their normal depth of non-adherence. So patient feedback can be a good thing. Reminders are also fun. These are devices that I used in the Merck study. This is called the Smartinhaler. On this side, you get information where they can set an alarm. And you can pick your alarm, and you can pick how you want the alarm, how long, and the frequency. And these reminding is a good thing. One thing about reminders is that when you do this, you should ask your patients what reminder they would like. There's a physician in England who studied children with severe asthma and gave them tracking devices, just like this one, and set the reminder so that it would go off for 15 minutes, and then it would stop if the patient didn't take it. And what they reported was, interestingly, they said that in the study, 50% of the parents brought the inhaler back, and they said it was broken. And you get the impression that these things don't bounce off walls; they crash. And so that it's important that when you do set your reminder, to do it in a consensual way. So the last one has to do with the model is enhanced communication skills. Well, and I'm a motivational interviewing trainer, so that's sort of my mode. I'm also a shared decision-making trainer, but I don't like that as much. And this is what shared decision-making looks like. What it does is there's two cards here. They ask, you give this to your patient, and you say, well, how well is your asthma controlled? And then they'll set the dial. And then, based on what the patient says, the clinician will set it as how they see it. What's the level of control? And here the issue is symptoms daily, frequent use of the beta agonist, nighttime symptoms. So by working through this discrepancy, you give as your healthcare information. You could do better. Is this something you're concerned about? Yes. And then you can share in the decision making. And here's an example of a study of adults where they started out with 3 groups. One was shared decision making in green. Well, actually, 3 populations. They started out essentially the same. And what they did then is they did the intervention so that the black was usual care, the blue was care with education, and the third was shared decision making. And what you can see is they're using a prescription refill data so that their adherence is highest with the shared decision group. But the thing to notice that as soon as they stopped sharing and decisioning, they all came back to the same level. So it's something that isn't sticky. You have to continue to do it. Now, the motivational interviewing is sort of a paradigm shift in healthcare from the doctor saying you ought to do this to patient must change, is that you should move the patient along a continuum. You help the patient to resolve ambivalence. And in doing so, you help build motivation and confidence. And that is the heart of the motivational interviewing. And the foundations are open-ended questions, affirmations, reflective listening, and self-motivational statements. Open-ended questions is, why don't you tell me about the difficulties that you're having, as opposed to, what's your asthma up to? Or, you're having much asthma lately? Yes or no? These are open-ended questions. Affirmations is, wow, that's impressive. Reflective listening is listening to what the patient says, interpreting what the patient said, speaking back to the patient, and see whether what the patient said is you have the right interpretation. And that is reflective listening. But the key thing on why you would have a patient with motivational interviewing as a intervention is that you want to explore ambivalence. Everybody's got ambivalence. In fact, you got to worry if you're so sure. I know a couple of politicians that are pretty sure they got no ambivalence. But more or less, you have to weigh the pros and cons of change. What are the good things? What are the bad things about your medicine? What are some of the, to summarize, empathize, and highlight this ambivalence? And there's all sorts of, I would call tricks that you can do that are very effective in using scaling questions and getting individuals to talk themselves into higher motivation and higher confidence. We have lots of examples of this, but since this is a quick run through, we're not going to show much of it. So I'm going to show you a couple slides and outcomes from a Merck study. And what I've developed is it's called a web app, and it's called the Asthma Adherence Pathway. And it works something like this. The patient fills out, clicks on, whoops, let's try this again. The patient fills out a questionnaire, clicks here and clicks there, similar to what was offered on the GINA guidelines list. They then immediately get reflex information back at the 5th grade level, and also a video that supports what that information is and will lead to more or less set up the intervention that the provider is going to administer. So the provider comes in, they're going to see the same questions that the patient answered, but theirs are going to be the clinical decision support strategies. And this is how, we have this backed up with extensive information for the clinicians in asthma management, adherence management, and motivational interviewing. And we have videotapes, instructions on the site as well. In this Merck study, we gave training over 2 days, 10 hours of all of the adherence strategy plan. And we used the Smartinhaler. And what we found is that we had the median age we had 20 in each group, control and treatment. Median age is around 40 years old for both of them. A little bit more women than men in the study. One of the purposes of the study was the primary aim of the study was to see if this intervention could improve asthma control. And what we used is asthma control monitored as measured by Juniper. It's called the Asthma Control Questionnaire. Individuals who have 0.75 have good control, greater than 1.5 have starting to be out of control, and the screening for this population was above 2, suggesting that they were having a bad day. They had FEV1 screening, and there was also, as far as emergency room, the control group had 4, the treatment group had 7 prior, and almost all were taking inhaled corticosteroid. So this is how the study ran. We had them fill out the barriers. We give them asthma education. They did that on the asthma adherence pathway. Then the clinicians would initiate the strategies. They would apply enhanced communication skills. And in this case, it was motivational interviewing. And then they were sent out. And they would come back initially 2 weeks and then monthly. And we would identify their adherence status using the Smartinhaler, and that the Dulera medicine, because these individuals had moderate to severe asthma, this medicine had both a long-acting beta agonist plus an inhaled corticosteroid. And what we did is then identified their asthma control. If they were taking if they had good adherence and they had good control, we said, we'll see you. If they had good adherence and poor control, we either thought that they might be not using the inhaler correctly or they needed to increase treatment. So that was the evaluation. If they were not taking the medicine and had poor control, then they would reassess the barriers and go through the process of the motivational interview. So here's what we found. So here's adherence at 2 weeks, 1 month, 2 months, and 3 months. The mean adherence was 88 plus at 2 weeks, and then slowly dropped to 76 at the end of 3 months. This is the 10th percentile for that group in each period, and the 100th percentile. If you take a look at the ACQ and you take a look at baseline value, this is the control at 1.5 and the treatment at 1.8, so that they improve slightly from the time that they were screened. And then at 1 month, the control pretty much went from 1.5, 1.4, 1.4. So they didn't drop very much. But you can see that with the treatment group, 1.8 all the way down to 1.1. And if you look at this and do a repeated measures ANOVA analysis over time, and the green is the treatment and the blue is the control, you can see this drop, and it's significant, showing that these individuals had superior asthma control. We also correlated the ACQ difference in patient self-reported quality of life. What we're doing is you take, what's your ACQ initially, what do you take later at the end? Then you take a look at the quality of life indicator initially and at the end. And we found that individuals who had higher and who had better asthma control was correlated with enhanced sleep, work, and family family activities and recreation. And if you took a look at issues like psychosocial, such as frustration, control, and feeling of a sense of dependence on treatment, you'll get a sense that by comparing the ACQ prior and comparing the quality of life measure, these individuals did better based on the correlation. So we're getting close to 10 minutes. I'm going to show you how you so-called play the game. I worked with Blue Cross Blue Shield of Delaware so far back, because now it's called Highmark, but they asked me to set up an asthma monitoring system program because I helped them a lot on that Morris thing. So what we did is, this is an example of a 45-year-old woman who's had 3 prior hospitalizations, depressed, anxiety, and had marital problems. And this is a screen from the asthma adherence pathway. And if you notice here, I remove myself from the area that may be causing symptoms, and the response is never. And I start treatment without delay, never. That, you can look at it, but for somebody like me, that is a big deal. So I remembered that very well. And what we did is send her out. She had a peak flow meter, electronic, and I would be able to make rounds every day on this patient. And she was up here, and all of a sudden she had a drop down here. And I went, how'd that happen? And then I began to take a look and saw that, let's advance this one, that she had been taking 4 puffs like she should have been of the inhaled steroid, but then dropped down to 2 and then actually stopped at the same time when the peak flow values dropped. And that the albuterol dropped off. So not only did she get worse, but she started taking less of the treatment. So what we did is have her come in, and we didn't wait for her to go to the hospital because we now know this information, and we treated her in the clinic setting. And at the end of the 1-year mark, instead of having 21 hospital days, she had 7. And during this program with Blue Cross, we had a 72% reduction in cost. So this is sort of how you do the game. Just want to finish up by talking about the NIH program, which is sort of in the midst of happening. And this is what would be considered a population health. What's different than the Merck study is that the patient is evaluated and they fill out the adherence pathway, and then they review the education program and counseling program, and they give barrier-specific strategies. But then we have home monitoring. So these individuals are given tracking devices, and it goes to a server, and the server more or less says, if the person's not taking the inhaled steroid medicine for 2 consecutive days, an alert goes out and goes to the nurse. And if the person's using more than 5 inhalations of the albuterol in a day, the alert goes out. And that's what happens here. And it comes to an email notification to the nurse. And then the nurse calls up the patient and begins the telephonic barrier-specific asthma adherence strategies. So more or less you can use, whereas the Merck thing was you bring it back and we'll take a look at it and download. This one is geared toward population health. So I think I'd like to stop here and entertain questions. I went through things really quickly. I just wanted to give you an idea of what goes on when one thinks about managing these patients.
Thank you for your talk. Could you tell us a little bit more about the patient interaction with the web app? Were there a lot of concerns with, patients interacting with this on their own, or did you find that the patients were really engaged with that app?
So the answer, I have the video material here, I can bring it up. They're extremely engaged. And, sort of like it's huge, it's great, it's wonderful. But the reality is that I had a contract with the Asthma and Allergy Foundation for America, and they took my program and then gave it to several thousand individuals on their website. And we found out that we had 90 questions, and we had 60% of the surveys completely filled, so that people were very engaged with the analysis. So is that what you were? Yeah. And when I started looking at stuff, I go, I didn't know it was that good. But then I sort of began to expect that, and it lasted through the 3 years. Yeah.
On the Merck study, who was the one delivering the motivational interviewing intervention?
So I tripped over. Very good question. So Merck really wanted to make this real world. They wanted to have doctors do it. So they had allergists and pulmonologists who did this, and we split up the group. So half the allergists were in the control, half were in the treatment, half the pulmonologists were in the control and treatment. And I've collected so far $650 by threatening to release the information of who's the worst and not. So there was competition in that. The control people knew something was going on. These people are all board certified individuals. It's not like, family practitioners who don't deal with asthma all the time. So it's impressive in that they were able to do this matched against somebody that's with those skills, but did not have the adherence package.
So if I could ask a quick follow-up. So contrasting the Merck study with GEISINGER study, question is it more scalable to teach board-certified physicians to do this in the room with the patient? There's an argument why that might be more effective, but maybe less pragmatic, versus the nurse phone-based approach, which you might say is more pragmatic, but may not be as effective.
So we don't have the data, but it's looking very heavily towards, they have very skilled people at the population health at GEISINGER. They know what they're doing, and they're very effective. And when I got there, and I said, okay, hi, my name's Dr. Weinstein. We're going to do some training. We're going to do motivational interviewing. All of a sudden I hear, oh, not more of that. So they knew, they were used to, they understood the thing, but they didn't. I have a different spin on it, a different approach, but that they eventually said mine was okay after all.
Thank you.
So in the GEISINGER study, I just want to make sure I understand. The patient first takes the questionnaire about barriers,
Mm-hmm.
and then this questionnaire is transmitted to the nurses, to the population health
So
coach.
well, we didn't know what was going to happen, but how good this was going to be, so that the patient would not do everything remote. Initially, they would be together. They sign a consent form, and then they'd jump in, and they would get the whole thing and given the tracking devices. They fill out the questionnaire, and they get the counseling. Then, after that, they were on their own, and everything was based on the results of the tracking devices. So it's in part at one place, and then and the rest in a telephone bank.
So how does there's a barrier, and then
So it's all electronic, and they can see everything. So they can see the responses on and what was done, the strategies initially, and then we have a field that shows what they're doing with the medicine, and then there's the strategies are what they do is then they type in the strategy that they give over the phone. Does that help? One thing too, one other piece of technology that when you sort of want something to happen and you want to make it, conservative. So we used IVR, Internet Voice Recorder technology. So every 2 weeks in the treatment group, these individuals actually from both groups, they were called and they push one. We were using the ACT test for asthma control. So the ACT has 5 questions, and each question has 5 parts. So they're cheating, but it's 5. And then check 1 if you're having symptoms more than 5 days a week. Check 2 if it's 3 days a week. Check 2, 3, and on like that. So the IVR then comes back to the nurse, and they use that as a level of control as well, so that if someone is out of control as measured by the ACT, then they get a phone call and to discuss it, and then they know what questions they answered, and they said, oh, you answered, oh, I didn't mean that, that was an error. Okay, but so in essence then you're doing anything you can to prevent emergency care. Make sure that they're taking preventative medicine, make sure that they're not using rescue medicine, and make sure that they're under control. So that was the design.
And how many patients do you have, or do you plan to enroll?
80. Yes.
The slide you had was, I forgot which study that was. It had like kind of the odometers for how well controlled the asthma is, like the patient perspective and the provider perspective.
Yeah, I'll get that one.
I was curious if, I guess I wanted to clarify. So did you find that there was like a difference of opinion or understanding of how you're defining controlling your asthma between the patient and the provider? Yeah, right there. Yeah. Yeah. That one. So there's a discrepancy, right, between patient report and provider report.
Appears to be, yeah.
So is it because they're defining it differently in terms of?
No, they don't. They think that using having symptoms daily is pretty good for them.
Okay, right. Oh, it's just a different perspective, right? Okay.
They have maybe, used to be that they've been in the hospital, been intubated 3 times, and now, that's not so bad. So the idea is you try to make do reality testing, but you have to do it in a nice way. And the patient's always right. And they might say, well, you might think that that's very poorly controlled. I don't think so.
Right.
Now, that's where the motivational interviewing might come. So when somebody says, no, you don't do motivational interviewing, you say, maybe you got it right. And that'll really upset them. If you say, maybe you're right after all, that'll really their head going. So, but the issue, this is the key aspect of having a reality check from a patient, a healthcare recipient, and a healthcare provider.
Thank you very much.